Let's go back and talk about CHF. You guys didn't miss much. A couple off-color jokes, but other than that, that's about all you missed. So congestive heart failure. Let's go back to a basic premise, so people understand things before we start throwing, long Scrabble words at you. So, in the most simplistic form, the heart is a pump. Okay, it is a soft tissue muscular pump, and like most pumps, when they're working properly, everything's great, right? You got a pump, you got a set of tubing, you got a closed circuit, you're pumping things through. All things are working well. Pressures are right, resistance is right, the pump is timed right, the sequence, everything is right. That's usually when you're younger and you're in good health, all right? That's when you're in your, teens and 20s and 30s and so forth. But like any long-running pump that pumps, 60 to 100 times a minute for 20 years, 30 years, 40 years, 50 years, eventually you're going to have some wear and tear on your mechanical pump system, right? That's the way it is. If it's a piece of equipment we have at the firehouse, well, we do preventive maintenance on it. We take care of it. We replace it or replace parts of it when they go bad and so forth. And we try to get the most longevity out of our equipment or out of our pump. All right. Well, in the human body, it's not that easy. It should be that easy, but it's not that easy. And there are things that we're doing now to recognize to try to protect our pump or make our pump more functional longer into our 60s, 70s, 80s, 90s, and 100s. So people talk about CHF. Well, CHF, it's an old person disease. Not necessarily. What happens if you're born with a bad pump? All right. What happens if electrically, you're a newborn and you have an electrical issue and your pump's out, or you have a hole in your heart, a VSD or an ASD, your pump mechanics are going to be off. What happens if you got problems with your tubing or your vascular system? That can happen. Now, fortunately, there's very few of those. And when we do see CHF in young folks, it is usually a structural issue in the pump. The pump is faulty. It wasn't designed right. It's got a hole in it. The valve's bad, et cetera, et cetera. So a lot of these kids that are in CHF, they get, how do we treat them? Well, we try medications and all of that kind of thing. But the best thing we can do is replace their pump. Or we go in and we patch the hole in their pump or in the diaphragm or the valve or so forth. And that's what's often done when they're younger, and it's a miraculous thing when it happens. But fortunately, we don't see a lot of CHF in kids, but it does occur, and I don't want you to forget that people of all ages can get CHF, not just the elderly. The majority of what we see are people that are older or made poor lifestyle decisions. These are people that did not take care of their pump. The smokers, the drinkers, the diabetics, the ones that are overweight, they got biscuit and gravy poisoning, et cetera, et cetera. They have tore up their pump system. They have put stress on their pump. They put stress on their valves, on their arteries, their veins, their plumbing, et cetera. And then we have some folks may get up their 70s, 80s, and 90s, and they end up having a pump issue just because a little bit of all those lifestyle choices catch up with them, but also their pump just wears out, right? We're asking a lot of our pump or our heart to beat 100 years flawlessly. Now, there are folks out there that do it, but it's less and less all the time. And as Americans get fatter and lazier and poison ourselves more with our diet and our activities or lack of activities and such, we're going to see CHF in younger and younger people. And we're seeing that now. We're seeing it, used to, you only saw CHF in either newborn babies that had a structural issue or the 70, 80, 90-year-olds that their pump was just wearing out. And they were starting to get congestive heart failure. But now we're seeing it in 30s and 40s and so forth. And obesity has a lot to play with it because why? Why would obesity matter? Well, if you put more weight on your system or more stress on your pump's going to have to work harder and wear out sooner. Okay, so that's a couple of the premises on that. So let's talk about what causes congestive heart failure in adults primarily, because pediatrics is a whole nother topic, although the principles are the same. And then what we're going to, the things that you can do pre-hospital that have the most bang for your buck as far as CHF. There's lots of things that we can do and that we do for CHF patients. But let's talk about what your highest yield and your most bang for your buck is. You guys think about which measure that's going to be, and we'll see if we all guess right. So over time, because either of age or lifestyle choice, or genetics, bad decisions, as our pump, our soft tissue pump, our heart is pumping more and more and more, we're pumping against higher pressures, right? We're pumping against higher pressures in our system because we're either fat or we're clogged with cholesterol or diabetes or we have some structural issues there. So our pump is pumping against a higher pressure. Well, what happens? Well, the pump starts blowing up, kind of like a balloon. It starts stretching. The heart's having to stretch because it's pushing harder and it's pushing more. And the heart can start getting flabby. After a while, the heart gets so big, and the heart's big, but mechanically and structurally, it's stretched too far. It's gotten lazy. It's gotten floppy. It's got flabby. You know, when we look at an x-ray of a 70-year-old with CHF, their heart is huge and it's thin-walled, all right? So if we cross-sectioned it in gross anatomy, this would be a big, floppy bag of muscle and fat. And as a result, it's not as efficient, all right? It cannot pump as well. There's more pooling inside the heart. The heart is lazy and floppy and flappy. It cannot push it all out. The ejection fraction is reduced. And, you know, they instead of pumping 50% of their stroke volume or so forth, you know, they're getting stroke volumes down into the 20s, teens, and so forth. And as a result, they're not pumping things all the way through the system. They're not getting blood all the way up to the brain. They're not perfusing the kidneys properly. They're not perfusing the internal organs. And what's the furthest place that we're pumping fluids through our system? Our feet. Right? And not only is it going downstream, because we have the benefit of gravity, when our heart is pumping and trying to circulate it back up, they're trying to pump it upstream against gravity. Well, we're getting some of it back, but some of it's not. So the serous fluid and lymphatic fluids and so forth are settling in our feet, and that's where we're getting the peripheral edema that we've all seen. And if you hadn't been doing it, I think everybody's been doing this long enough, but you'll get to the point where you see these big stovepipe legs that are just weeping, and you can just wipe your hand across it, and they're wet. You're like, where's this water coming from? They piss down their leg? No, it's the serous fluid coming through their legs, because their pump is so weak it's not cycling it back up into the lungs. So we see it pooling first in the legs or ankles and the hands. Why do we see it there first? Gravity pulls it to the lowest point, right? The heart has to pump hardest to get it out of there. It also will start backing up, and you can see edema anywhere in the legs and the scrotum and the soft tissues. If you let CAT scan or MRI some of these people, their mesentery, you'll see fluid around their mesentery, the ascites and so forth. The other place that we see it that impacts us pre-hospital is in their lungs, right? So they're not able to pump that fluid adequately out of their heart fast enough. This fluid backs up in the soft dependent areas of their lung, and that's where we hear the rowels, right? And it's hard to breathe underwater, right? So it's hard to exchange oxygen. So these people, their heart's having to pump harder to get the fluid out of their lungs, and as a result, it's causing more stress and strain on the system. So their oxygen levels start dropping. They start having to ventilate harder. So they start getting more tachycardic. So it's this vicious cycle that just gets progressively worse as far as that goes. So we're getting fluids in our ankles, we're getting it in our hands, we're getting it in our lungs. You know, when you listen to these people, and most of you know this, Well, water is going to settle where it's dependent, right? Or fluid's going to settle when it's dependent. When you set them straight up, the fluid's going to settle to their base. So when you're listening down below, that's where you're going to hear the rowels down at the base of the lungs. All right. When you lay these people flat, they don't like that. Why don't they like it? Well, when you lay them back, the fluid's getting dependent all horizontally across their lung base. So a lot of these folks will breathe better if they're setting up and oftentimes forward, because mechanically there's less surface area of the fluid that's dissipated through the lungs and they can oxygenate easier. Okay, so real simplistic terms and probably oversimplistic terms, but sometimes we have to hear those to understand some of the things. So now that we can kind of conceptualize why our patients get CHF, what are we going to do about it? There is a bunch of things we can do about it, but pre-hospital, there's only a couple of things that really make a difference. All right. Anybody got a guess on what the big issue is? Yeah. The big game changer, yeah, besides bloodletting and rotating tourniquets and so forth, although rotating tourniquets are coming back into style, believe it or not, in the ICU. CPAP, BiPAP, okay? And why? Well, before that technology went on the streets, what were we doing for these patients? We were giving them oxygen, all right, trying to ventilate them better because we knew that they were having trouble oxygenating. And we would give them a diuretic, right? We're going to take some of this fluid out of their system. Great concept, great idea. We still do it, but from a pre-hospital standpoint, how fast does it work? Not fast enough, right? So you give somebody a big slug of Lasix, and I used to do it in the back of the squad because I wanted the nurse to have to clean it up when they got there. But, how long does it take to work? 20 minutes, 30 minutes, and you usually have to give them a pretty good slug of Lasix. Now, we've all had these patients, as soon as you give them the Lasix, they want to pee. But as far as really moving the fluid out of their system, diuretics take time. It's still important to use. We still use it, still want you to think about using it and so forth. But you're not going to see, it's not typically going to be a game changer in the back of your squad when somebody's getting ready to crump. Oxygen, that will help. That's something that's cheap, it's easy to do. That's obviously going to make your patients more comfortable. Diuretics, we talked a little bit about that. What else did we used to do, or that we still do some? Well, we used to give morphine and nitrates, right? Well, why do we give morphine and nitrates to these people that are in florid CHF or florid pulmonary edema? A couple of reasons. One, when you are drowning, it is an anxiety-provoking event. When you can't breathe and you're underwater, it's scary. So what happens? Your heart rate's going to go up. You're stressed. It's a miserable experience for your patient and for you. So we would give them the morphine. Now, we don't do it just for sedation and just for comfort. It also does some other things. What does morphine do? It causes histamine release and vasodilation and affects the preload and so forth. We're not going to get too much into preload because I don't want anybody else going to sleep. But the next thing that we do is we use nitrates. All right, and we still use them. They still work pretty well. What does nitrates do? Well, it dilates the coronaries. And not only does it dilate the coronaries, it dilates all the other blood vessels. And it changes the preload on the heart, making that mechanics of pumping the fluid through the heart and the lungs, more efficient and such. So those are the main things. But the main thing that really is a game changer pre-hospital is mechanically pushing the fluids out of their lungs, right? Getting the fluid out of their legs, that's not going to save your patient acutely, That's not what we're trying to do. We're trying to make it easier for them to oxygenate before they stress their heart further, stress their brain further, and their organs start shutting down as far as their kidneys and such. So mechanically is the way to get that fluid out of the lungs. And that's when the PAP technologies come in, positive airway pressure technology. You are physically putting back pressure in your alveoli to start pushing that fluid out of the alveoli back into the vascular spaces and so forth, so your patients oxygenate. And PAP technology does reduce the incidence of intubation. You guys have been doing this. I know you say, how many times have you prevented having to intubate a patient when you just put them on, a PAP? big percentage of the time. There's some departments that are intubating, less and less and less all the time because they're going to that first, and there's nothing wrong with that. It's fairly easy to set up. Not all patients will tolerate it, but most of them will, but you got ways to make it easier for them to tolerate and such. And, what I do in my situation with these patients is I'll tell the RT, go in there and throw them on a PAP setting. And while we are getting everything set up, while we're getting our vents set up, while we're getting our medications set up, while we make sure, the nurses are caught up with the rest of the department, we're slowing things down and controlling them so we don't have to do a crash airway. Now, if we got to do a crash airway, we do a crash airway, we intubate them and go on with it and put them on PEEP on the vent. But you can use a CPAP to bridge that situation where you can get some of that fluid out of the lungs, make your patients more comfortable, take the stress off the heart. That's it. What I missed? Anything on CHF? A quick little overview. All right, good. We got about 15 minutes left, which is just about right. I think I went over all the CHF stuff. I did not use fancy terms like resistance, and you did use preload. Sure, shouldn't have done that. Peripheral venodilator, dilate. Okay. All right. Can these guys see all this?
So then I'm gonna make it
switch it over. Okay. Next time I'll wear a ball cap. That way you don't have to see the sheen bouncing off my forehead. Yeah.
Can you guys all see the wide complex tachycardia now?
Thumbs up if you can.
Yeah, we're good.
Everybody can see the PowerPoint presentation. All right. Okay, we're going to talk a little bit about wide complex tachycardias. And we're going to try not to make this complicated because we could. And some people will find it complicated enough. But we want to add a particular percentage of our population that if we're doing what we're doing with wide complex now, we'll kill them. All right? And we're even going to talk about a concept called a clean kill. And these are patients that have a wide complex tachycardia appearance on telemetry, but it's a mimic. And if we do some of our traditional measures as far as our antiarrhythmics, you could kill these patients. And I'm not trying to sound dramatic, but there is 6% of the population that if we treat all of our wide complex tachycardias the same, research has shown that we'll off 6% of them. That's kind of scary. So let's do what we got to do to not get scared and try to save those 6% because that may be the only 6% that you save. So that's why we brought this up, and that's why we're going to talk about it a little bit. We're going to go over a few basic principles, and we're going to throw in a video at the end by a much better teacher than I, a guy by the name of Amal Mattu. He's an ER doctor, a very well-known ER doctor. He is the ER doctor that we all go to when we want to learn anything and everything about cardiovascular emergencies. This guy is the Yoda of EKGs. And he's a good speaker. People pay a lot of money to go see him, but in the days of YouTube and MRAP and all that, everybody can watch him, and it's worth watching this little 6-minute video at the end. So let's get into this here. Hit the center button. There we go. All right, scenario. Okay, dispatched and arrive on scene. 46-year-old male complains of chest palpitations, shortness of breath, skin was pink, warm, dry, blood pressure 100/80, CVG 116. Respirations were clear with no distress noted. All right, sounds like a guy on the trail system here in Bella Vista, right? So a guy goes out, rides his mountain bike, he's a weekend warrior, and you guys get called out, and he's got palpitations and shortness of breath. mean, this sounds like a patient that we all see, right? Is there anything there that jumps out at you? Not much. You know, he could be hot, he could be scared, he could have lots of little things. You know, is this one that would make you get excited? Not necessarily, but since it's a teaching scenario, there's got to be something here. This is his EKG, all right? And, you know, what do we see here out of the gate, all right? Heart rate's fast, and he's, I don't know, 150, 160, 170. I can't see my lines. What's the computer say? Computer says 165. All right, okay, I was close. I was just eyeballing that. He's not 91, he's 41. Do not get hung up on meets ST elevation in my criteria. I heard something funny the other day. They said the people that program that little box up there are trial lawyers, and they want you to be misled and so forth. And computer technology is not there yet. Do not look at the top because it will lead you down the primrose path. Look at EKG itself, make an educated guess. Then if you want to look at the box or take a little peek, do it, but do not get hung up on the box. It will lead you down the primrose path more than once. I can vouch for it. There are some departments, emergency rooms and EMS departments, that turn that function off on their EKG machines to where it just won't print it out. And I understand that, and because it will cause you to make some wrong decisions. Okay, so what do we see about this guy? It's fast. All right. So is it a narrow complex or a wide complex? All right. I think I'd say everybody says that's probably wide, right? I don't think we'll get too much argument there with it. Look at the size of your QRS and see how big it is, and so forth. You can cheat and look at your PR intervals or your QRS intervals. Those measurements are valid. I think that's a good box to keep on there, and you can see how big it is. This guy's QRS is 0.142, his PR is 0.12. We got QT out there, corrected QT 0.489, so big and wide on it. Now, just want to plant a little seed here, and I don't want to say the wrong thing, but look at the QRS complex, and I don't think I have a little laser here, so I can't tell you, but the guys that are here, I'm going to show you. You got the ST, you got a point here, and you got a point here, right? Look how wide it is from here to there. Look how wide it is from there to there. Now, we don't have the benefit of our grid, but is this guy really, really tacking? Or is the computer telling us that rate is that fast? Sometimes you'll find that the computer is lying to you. Yeah, like a bad girlfriend or boyfriend. So, all right. So treatments. So what are we going to do with this? What are we going to do with this guy? Man, look at that picture. Did you do that?
I grabbed it off the internet.
Oh, okay. That's kind of.
That's kind of cool.
Yeah, it's kind of airbrushing. That's a pretty good picture. Yeah. All right. Yeah. That's a little different event on their monitor there. So, all right. So let's talk about treatment. So, all right. So your brain hopefully goes right to the VTAC protocol and so forth. If not, you can look it up. We're just going to hit the high points on this because these things will make you go to sleep. So ventricular tachycardia, look at the rate. He was over 150. He was 160-ish. We decided he's wide complex and so forth. We're going to go down our universal patient care protocol. Is it VFib or not? Everybody knows how to do that. We're going to make the decision, is this guy stable or unstable? If he's stable, what do we want to do? Well, ideally, we'd like to get an EKG and get a little better idea of what's going on. We determine it's a monomorphic wide tachycardia. We think about things like adenosine or amiodarone. And If they become unstable, then we're going to go down to the consider cardioverting them. A little bit about amiodarone, and I never really thought about it this way, but Matu made a really good comment about, amiodarone has gotten real sexy in the last few years, and we use it for a lot. There for a while, we were using it for everything. We were using it for too much of things, I think, because it would just kind of go, you didn't know what to do, or you weren't sure, or there were lots of things going on. You said, well, just give them some amiodarone and see what happens. Sometimes it worked, sometimes it didn't. Matu says that amiodarone is an antiarrhythmic class, but basically it's all four classes. It has some beta blocker activity, it has calcium channel blocker activity, and so forth. It is kind of a magical drug because it works in multiple different ways with that. That's good when you need it, but sometimes it can be bad also, and we'll get into that a little bit. So let's go. Let's say, all right, are they not stable? Well, they're not stable. So how do we know they're not stable? Obviously, decreased LOC. They're not talking to you. They don't know what's going on. They're starting to have chest pain. They're really tugging. They've got that impending sense of doom. Say, well, they got pulmonary edema. Well, yeah, you can be throwing some PAP technology on them there, or have your partner do that while you're getting ready for the show. So you look next down and say, okay, is this torsades or not? It looks torsades-ish. So if we'd already made the decision to do amiodarone, we probably need to stop it. But we're going to go right to magnesium, and magnesium helps, but we need to be ready to cardiovert them if they're unstable. And we talked about doing that. They're unsynchronized, cardiovert 200, and so forth. Consider external overdrive pacing. Rarely will you guys get that far down the pathway. If you do, you get a gold star, because sometimes that is a game changer for these folks. So, all right, let's say it's not really torsades looking, but we're thinking about trying a antiarrhythmic or cardioverting them. So if they are unstable, it's not really torsades, then, what's the drug of choice? Well, it would be, sedation and cardioversion. Somebody said, well, drug of choice might be, ketamine or propofol or those types of things. But consider going down into amiodarone. So what we're going to do is I want you to know this pathway and think about it and think through it and so forth, and we do, but we're going to throw another little box in here at some point to try to prevent a clean kill on these 6% of patients that would have a problem with this protocol. Okay, here are a few little notes down here. What do we need to hit here?
Nothing.
Nothing? All right, more of the same? Okay. All right, so same patient, I assume, right?
Mm-hmm.
25 minutes later.
Post amiodarone.
Post amiodarone. So what happened?
So a little bit.
Yeah, not much, right? His heart rate's 140. He's still wide. EKG is a little easier to read just because his rate's slower, but we really haven't done much to his cardiac physiology. I'm like, well, damn, doc, what do we do? What we did really didn't work. And the guy is not necessarily unstable, right?
Mm-hmm.
This is a young, healthy guy on the bike trail type thing. So like, well, I don't know, what do we do? Well, we drive fast. No, there's some things to be thinking about. So what we're going to talk about before we start this is I'm going to give you a little overview, and then I think this is about a 6-minute set or so. There is a subset of patients that we think about tachycardias, and a lot of times we forget, all right, well, why are they tachycardic? Why are they tachycardic? Well, most people, the tachycardia is because it's a cardiac abnormality, a cardio electrophysiology issue, and so forth. And as Matu will mention, our ACLS guidelines are really written for people that
have cardiac events, right? The 60s and 70-year-olds, and they're diabetic, and they got CHF and high blood pressure, and they smoked, and what have you. But we're not really thinking outside the box. It's like ACLS experienced provider. This is an ACLS experienced provider pearl that we want you guys to raise your game on. There's a subset of patients that it's not because of that, it's because of toxicology issues or electrolyte issues. And that's where we're going at. Not all wide complex tachycardias are ACLS. They don't all fit in the ACLS box. There's a percentage of them that are due to either electrolyte issues or toxicology issues. And we're going to show you a real simple way to pick out those patients. Because if you do treat them with your normal pathway and go down giving them, fortunately nothing bad happened to this guy, but if you give some of these patients beta blockers or calcium channel blockers or amiodarone and such, sometimes their arrhythmia goes from making you nervous to I screwed up, and we don't want that to happen. When early in my career, we were trained on these patients that if we saw a young 40-year-old patient like this and their wide complex tachycardia was present on their EKG, and we had very limited history, I would reflexively walk into the room and look at the monitor and go, that's a tricyclic overdose. Guy's 40, he's not fat, he's not diabetic, he's not a smoker, he doesn't have cardiac disease. He's too young to have cardiac disease. It's different now. We have a lot of 40-year-olds with cardiac disease. So I said, I can look at the EKG and say, okay, something's wrong. It's not a cardiac issue. It's a toxicology issue, because back in my day, we saw a lot of tricyclic overdoses. Elavil and amitriptyline was it. All right. And I remember very well, some of you guys have been around long enough to remember Monty Gagliardi. He and I were working in the ER one time back in Springdale, and there was a 30-year-old girl comes in and had an EKG very similar to that. Complex is getting wider and wider and wider and wider, and of course I'm young, kind of scratching my head, going, what is that, and so forth. And Monty had a box of bicarb in his hand. He just kept kind of walking a little closer to trying to give me a hint. And then finally I was like, oh shit, that's, I bet she took some Elavil, and, because her complex is getting wider and wider and wider. And if we had not, worked a little, or I had not, Monty was working plenty fast. Is very smart paramedic. Was working in the ER with us. And if we had not, that tachycardia, complex tachycardia, eventually got out the flat line, and it was starting to do that. So we would give them bicarb reflexively, and their wide complex tachycardia would start getting narrow again. And it was magic. You could see it on the EKG. And so right before they got wide and flat, you could give them that bicarb and bring them back in. Well, not a lot of patients take tricyclics anymore, right? There's a lot of sexier antidepressants out there and so forth that there's commercials and magazines for and so forth. And they work totally different. So you don't see a lot of patients that take Elavil or amitriptyline or nortriptyline or what have you. But 15, 20 years ago, they all took it. It was the Prozac of that generation. So we didn't see a lot of that. So now when we see these, what's the other thing that most commonly see? It's an electrolyte issue. And the number one electrolyte that is the cause is a potassium issue. All right, they can be hyperkalemic, have high potassium, and they can start having a tachycardia, a tachycardia like this. So we need to be thinking about how do we catch this subset of patients and protect it. It's really pretty easy, and he's going to go over it. I don't want to steal a lot of his thunder. But if you see a wide complex tachycardia, or what he calls a really wide complex tachycardia, and if you look at this EKG that he's got up here and the one that we had, it was wide. Not only was it wide, it was really pretty wide. And the rule of thumb is if it's bigger than one big box under your complex, then you need to start thinking about it being a regular, really wide complex tachycardia. And these are the patients that you could cause harm if you use our traditional guidelines. They say 6% of them, things can go really bad. But if you give them a little touch of calcium and a little touch of bicarb, their complex will get narrow again, and you'll save them, and you won't hurt that 6% of the population. So that's what this whole premise is about. I'm going to let he'll explain it better than I have, and then we'll go over it, and then we'll talk about a little bit more and answer any questions, and then we will be done from my standpoint. Sound right? All right, so watch this little quick video. It's 6 or 7 minutes if I remember right. But just so you guys know, that initial EKG did come from Northwest Arkansas. It was taken around here. So this stuff does happen.
So next up, we're going to change gears and talk a little bit about electrocardiography and ECG mimic. Now I've got 10 minutes. So I think the title of this was Tricks and Mimics. And I'm only going to talk about one mimic. And I'm going to really try to pound this mimic into your heads over the next 10 minutes or so. So again, back to your real case. 45-year-old male who was not feeling well, complaining of palpitations, no surprise. Blood pressure is 115, so not too bad. And what you see up here is this wide complex tachycardia, looks fairly regular. And so what is your drug of choice? All right. Now you could say my drug of choice is propofol followed by 200 joules. And I would not argue with that. All right. Fantastic. It's fast. It's reliable. Kind of fun. You bill more for it also. But let's say that this patient's wide awake and he's like, no, give me a drug. What is your drug of choice? Well, I'll tell you what the physicians in this case use. Again, this is a real case. They chose amiodarone. Now, if you know me, I'm not a big fan of amiodarone. I like procainamide a lot more for regular wide complex tachycardias. But if you substitute procainamide or lidocaine for this, you get the same outcome. This patient bradyed down and died. And I found out about the case a little while later on. We'll go back to what we're actually looking at. This is a regular wide complex tachycardia. Maybe it's just a tiny bit irregular. But when I see something like this, instead of calling it an RWCT, what I actually call this is an RRWCT. And what does the extra R stand for? Regular, really wide complex tachycardia. It's not just wide, it's really wide. And what I mean by that is that when you see the QRS complexes greater than one big box, greater than 200 milliseconds, I don't want you to ever think about VTach as your number one diagnosis. The first diagnosis I want you to think about whenever you see a regular, really wide complex tachycardia is tox or metabolic. And this is so important because if you follow a standard ACLS, what does ACLS tell you to do when you see a wide complex tachycardia? Lidocaine, amio, or procainamide. All of those are sodium channel blockers. And if you give this patient a sodium channel blocker, it is what I refer to as a clean kill. It's a very reliable way of killing a patient. Whenever you see the really wide complex tachycardia, just give strong consideration to empiric use of calcium and bicarb. Because if you go with ACLS, ACLS will kill this patient. All right. Remember, ACLS was never written for tox or metabolic patients. ACLS was written for the 65-year-old man who smokes 2 packs per day of cigarettes, who eats cheesesteaks for breakfast, lunch, and dinner, who one day clutches his chest and falls to the ground. That is who ACLS is written for. You can go out to the casinos or on Las Vegas Boulevard. That is what ACLS was written for. Honestly, it wasn't really intended for a lot of patients that we see in the emergency department. And if you employ ACLS, this is one of those conditions where ACLS will kill your patient. And remember, what's the first law of medicine? Primum, no, kill them. Okay? And if you follow ACLS, you are going to kill this patient really, really, really quickly. This was hyperkalemia. The patient's potassium was 9.2. Again, a real case that was seen at one of our hospitals, up on the floor, actually. This was an inpatient who, for whatever reason, developed hyper-K, and the medicine folks that saw this, the inpatient physicians that saw this patient, thought this is wide complex tachycardia. ACLS tells you, give them amio. Amio is good for everything. Procainamide would have done the same thing. Lidocaine would have done the same thing also. We've seen those cases in our own practice and learned from those mistakes, so now you learn from the mistakes that we made. When it's really wide, do not use any of these sodium channel blockers that ACLS tells you to. Why is it? Well, hyperkalemia is actually a sodium channel poison condition. Hyperkalemia poisons the the sodium channel. So it's almost like having a tricyclic overdose. And you would never want to use a sodium channel blocker if your sodium channels are already screwed up, all right? So stay away. That's the whole lecture right there, all right? But I'm going to show you a handful more cases just to really, really hammer home this key point. This is a 42-year-old man, short of breath and weakness. It's a wide complex tachycardia, but it's a regular, really wide complex tachycardia. Take a look. Normal VTach just doesn't get that wide. When you're looking at something that's greater than 200 milliseconds, think tox and metabolic first. Just give him some calcium and bicarb. If it is tox or metabolic, you're going to see the QRS narrow right before your eyes within a minute or two. If it narrows before your eyes, it's not VTach. VTach doesn't do that when you give the bicarb or the calcium. On the other hand, if you give the calcium and bicarb and nothing happens, then fine, go ahead, call it VTach and use the others. But first think about calcium and the bicarb first. Sometimes people say, well, what if it really is VTach and I give calcium bicarb? What's the harm? What happens if somebody truly has VTach and you give them a couple amps of bicarb? What happens to them? Nothing. If I gave everybody in this room 2 amps of IV sodium bicarb, nothing happens. It gets metabolized and is out of your system in about 15 minutes or so. What happens if you give calcium to somebody who's not actually hyper K? What happens to them? Right? Their bones get stronger. It's great, right? There's no harm at all. There's no harm. Just try the calcium. If it's hyper K, you just saved a life. If it's not hyper K, no harm. All right, so a few more cases. Take a look. This is another hyper K. The patient potassium was in the upper 7s. This is a patient that was severely acidotic from sepsis. This was misinterpreted as VTach. It's too wide for VTach. The other thing, as we mentioned earlier in the lecture, the first lecture, is too slow. VTach has to have a rate of at least 120 or 130. The rate here is only about 110 or so at most. This is too slow for VTach. This is either tox or metabolic. When it's slow and really wide, tox or metabolic, the patient here got some amiodarone and bradyed down and died again. The reason for this, why did this person brady down and die? It wasn't a sodium channel problem, but it's not well known, not marketed this way, but amiodarone is actually a beta blocker and calcium channel blocker. Right? Amiodarone is marketed as a class 3 antiarrhythmic potassium channel stabilizer. In reality, amiodarone is class 1, 2, 3, and 4. Class 1, sodium channel blocker. Class 2, beta blocker. Class 4, calcium channel blocker. Would you ever give a beta blocker or calcium channel blocker to somebody with a slow, wide, complex tachycardia? Of course not. There's no reason to. And what happened? Amiodarone was given, and they brady down and died. Right? This patient needed bicarb. Here's a hyper K. You see the answer up there. It's 8. Rate's 115, so right off the bat, you know it's too slow. And let's take a closer look. It's way too wide. This has to be tox or metabolic. Look how wide that is. And if you follow the EKG machine, it's going to have you kill this patient. Just like we said yesterday at the EKG conference, who programs EKG machines? Plaintiff attorneys. They want you to kill the patient, right? That's how they make their money. They want you to kill the patient. So don't ever believe that interpretation at the top. Here's another one. Nortriptyline overdose, sodium channel blocker overdose. It's too wide, and by the way, it's only about 115. It's too slow to call it ventricular tachycardia. Give some calcium. Calcium won't help here, but it won't hurt. And give some bicarb. You'll see the QRS narrow right in front of your eyes. Here's a flecainide toxic patient. Take a look at V1. That's way too wide to call it VTach. When it's that wide, just try some calcium and try some bicarb. You'll see the QRS narrow right before your eyes, and you'll have your diagnosis. This is a great case. This is from one of my former attendings from residency. He's a program director down in Florida. He took care of this patient. They didn't know the potassium was 8.8. It's a regular, wide, complex tachycardia. Everybody around him is saying, Dale, give the patient amio, give him procainamide, do something. The patient's got VTach. He said, no, it's too wide, and the rate is just a little bit too slow. So he said, you know what, let's just try some calcium bicarb. He gave 1 gram of calcium, 2 amps of sodium bicarb, bam, take a look at what happens. It narrows down, converts, you've got your diagnosis. This is just hyperkalemia. If he had treated this patient with lidocaine, amio, or procainamide, he would have killed those sodium channels. He would have ended up killing the patient, all right? So, simple take-home point. This is a common mimic in the emergency department. Many other specialties don't see this. We see this oftentimes in the EP. We see hyper-K all the time. We see overdoses all the time. When you see regular, really wide complex tachycardia, don't call it VTach until after you've tried some calcium and bicarb. If you do that, you'll save a life. If you go right to ACLS, some of your patients will end up dying. When in doubt, go with the calcium and sodium bicarbonate. All right, that's it. Thanks a lot.
All right, ready?
Ready.
Everybody still online?
Yep.
Okay, so I'm Alma too. Hopefully he was able to elaborate on that a little bit. I would encourage you to seek this guy out and watch some of his videos. When you have trouble understanding stuff or there's something progressive, he really is a great resource, and he's a good teacher. So, and his stuff is all over the net, and you can find it and go over it. So he has a really good way of explaining things and good real life examples. And is a good speaker in general. So, all right. So this is they can all see this here. All right. So this is our current.
This one, our current one is.
Yeah, this is all right. So these are what we're talking about. Is we've got our current algorithm which we reviewed, and we are trying to decide, okay, how do we incorporate this new thought process and some of this new thinking into the next rendition of the algorithm. And this is kind of where we're at, and you guys can kind of help us think through this. So wide complex tachycardia, patient care goals, all pretty straightforward there. But look at the top. Go back up just a little bit. Where are we looking at now on number 4? We're going, okay, think about medications and drugs, history of dysrhythmia and CHF. You know, what's at the top? Medications, toxicology, thinking about electrolytes and that kind of thing. And we've got the CHF a little bit further down. So it's laid out that way for a reason. So patient presentation, they go for elevated heart rate for their age. We're talking about criteria, heart rate greater than 100 or relative tachycardia in pediatric patients. If this is going to be, this isn't just sinus tach, this is wide complex tach, right?
Yeah.
So that rate, probably going to be a little higher, but they have to have at least meet the definition for tachycardia, of 100. So, all right, I got there. Exclusion sinus tach. All right, so we're trying to decide is this, wide or not. Patient management, all looks pretty straightforward. Blood glucose, didn't see much in there. So here we go back down into our regular wide complex tachycardia, suspected toxicity or metabolic. So probably, I guess what we are there, we could put consider suspected toxicity or metabolic. Would probably be a way to do that. Maybe put that in bold letters because we're wanting you to consider, do this on the fly, that way it will be done. Or metabolic, and that's going to be electrolytes, right? Okay. So patient with known hyperkalemia or patient with renal failure, suspected hyperkalemia. So who are we going to see in the Bella Vista population that's going to be hyperkalemic, right? It's going to be our dialysis patients. So if they have a dialysis port, if they've got a big line stuck in their chest or their neck, or they're a home peritoneal dialysis patient that's screwed up, and we're seeing a lot of those now. Everybody's familiar with home dialysis, right? Peritoneal bottles and stuff. So if you have a dialysis patient, when you walk in the building or walk in the room, you need to be going, all right, what about their calcium? What about their electrolytes? What about the potassium and all that? Now, you're not going to be able to measure those things, but you can make some educated guesses. So be thinking about that. If you walk in on a dialysis patient and they're tachycardic and it's wide complex, think potassium. So patient with known hyperkalemia, renal failure, got that in there, good. Presence of hypotension or marked QRS widening. Probably need to put in here somewhere about, if they're bigger than if it's greater than a big box on the QRS, so if they're greater than 200 milliseconds, or then we want you to start thinking about a regular, really wide, complex tachycardia. So RRCT, kind of like he voiced it. So consider calcium chloride. Now let's talk one thing about, and we need to put this in here. Calcium chloride and bicarb, if you put them together or you flush them too fast together, they will precipitate. You'll get little pieces of baking soda granules in your IV line, and that's not a good thing. So in a perfect world, you would have 2 IVs. You put one in one and one in the other. All right. If you do one versus the other, make sure you flush really well before you give them, or it will precipitate in your line. It'll get cloudy and so forth. So just remember that. So we've got here, consider calcium chloride, 1 gram. That's what, about 10 mils or so.
Yeah.
Yeah. Avoid if DIDGE. We don't see a lot of DIDGE anymore. Flush with normal saline. All right, keep going. Bicarb, there's your bicarb. That's all the same.
Mm-hmm.
That should all be.
Everything else should all be the
So
same.
everything else really looks all pretty good. So what we need from you guys is, do those few changes make sense? Will this, if we rewrite this, will that help you catch this 6%? Or do we need to word it different for the average medic?
So basically, with our standard treatment regimen, if we get this wide complex tachycardia,
Yeah.
and we suspect VTAC,
Right.
we're not real sure. We're
Right.
going to go ahead and try calcium and bicarb first.
Yeah,
No change, then
Yeah.
we're going to move on to amiodarone.
right.
One question I did have.
Unless they're totally unstable. If they're totally unstable, you know what to do.
Right. Well, and that was actually what I was going to ask about. If we have an unstable patient with a wide complex tachycardia,
Mhm.
and we cardiovert that patient, if it's a metabolic or toxicity patient, is that cardioversion, or is that going to work?
Is it going to work? Sometimes. If it does, it's not going to work very long.
Okay.
So because you didn't correct the underlying issue. So,
So if we-
ideally, you should be doing it. Be consider doing it all. Yeah.
Okay.
Yeah.
So if we if we cardioverted and it was consistently coming back,
Right.
well, of course, I guess it wouldn't matter.
Yeah.
You're going to do all of it.
You're going to do all of it. Right. Yeah. That patient's going to be getting probably amio or procanamide to stabilize the ventricle, and the calcium and the bicarb is sure not going to hurt them, and it sure might help them.
Sure.
And and think about these patients that are getting unstable. The ones that are unstable, they have really wide complexes and are really, the ones that we see that are unstable, most of them, do they have really wide complexes, and are they beating really fast or really slow?
I would think really fast.
Yeah, most of them are beating really fast. So those are the ones that you're going to electrically cardiovert. The magic with the calcium and the bicarb is the patient whose QRS complex is getting so wide that it's getting fast. It's fast, but all of a sudden it's getting slow. And if you let it go long enough, what's it going to do? Yeah, it's going to get bradycardic, and they're going to flatline.
Gotcha.
So yeah, cardioversion, electrical cardioversion still makes sense for those that are really unstable. Now, if you tell me the rate looks 150 or 160, and man, their QRS is really wide and they're looking unstable, which is better to go? Calcium and bicarb, because those patients are going to have rates of 160-ish or 170-ish or whatever, and you're probably not going to shock that patient anyway. You're going to go, well, their rate's not really that bad, and their QRS is bad. Man, they just look bad. What am I going to do? I'm going to go ahead and make sure we're ventilating them and so forth. But the point is that the calcium and the bicarb won't hurt, might help. And you're going to get those 6% from what he calls clean kill or silent kill or what have you.
So what about patients that we discover have this really wide tachycardia?
Yeah.
I'll go ahead and call it that. But we got, that's not why we got called. You know, we got called
Yeah.
because they tripped going down the stairs.
Right.
And we discovered this. Is
Right.
this something we need to go ahead and treat?
Well, first you need to go, what is the number one cause of a wide, complex-looking tachycardia on an EKG or telemetry in Bella Vista, Arkansas? A pacemaker.
Right.
Right?
Yeah.
Right. And I cannot tell you how many times, you know, somebody brings them in, and it's at all the hospitals I work at and whatever, and they go, oh my God, look at that wide, complex tachycardia, man. And, you know, the guy's talking to them and asking for a cup of coffee and a blanket and whatever, you know. And you can't see the pacer spikes, but they got a really ugly looking EKG, and you just walk over and look under his shirt and he's got a scar there. You know, that's the no. So that patient need to be treated. No, you know, I mean, you got a pacemaker. You got a pacemaker. You know, their electrical axis is all screwed up because we put an electronic device in their chest, ran wires there. So no, that patient doesn't need to be. But if you got somebody that doesn't have a reason for a wide complex tachycardia and they've got that look, then, you know, and most of these people, they're going to look like crap. I mean, if they got a potassium of 7 or 8, most of them are going to look bad. I mean, they're going to have the color and they're going to look like a renal patient and what have you. The only time that you're going to see this that might not be the case, and they're going to be polypharmacy too. They're going to be on all kinds of crazy diuretics and spironolactone and phalidone, and, you know, it's not going to be your simple patient that's on Zestoretic or something. The only other time you're going to see it is you're going to see it on one of these, I'm going to say this politically correct, weekend warriors that gets out here on the bike trail, and they did CrossFit 4 times last week, and, you know, they're out here and they just got themselves dry, and they're too dumb to stop, and then the potassium goes through the roof and they get dehydrated and what have you. That's the time when you're going to see it in a normal person. And those people aren't normal. Yeah.
How about a
Yeah.
firefighter that's not properly hydrated?
You could do that. Yeah. That's another, you know, don't want to call anybody dumb. That's another dumb person that didn't hydrate, you know, while they were working. And that, I mean, that happens. You know, you get out in the heat and you guys got a tough job, and that's why, you know, you feel like Papa Bear's running around here saying hydrate, hydrate, hydrate. And you're like, you know, but yeah, it is. I mean, it is important because you guys could get around the fire and or just be out in the heat. You know, we've had that, and some of these guys, you know, are working out all day and drinking, you know, creatine lotion potions and anaconda skin, you know, Tommy copper sleeve, you know, rattlesnake juice and all that kind of stuff. And then they get out and they, you know, they're doing that and they do it. And I've got a few names if anybody needs them, of firefighters and police that have done that in the last year. Ended up in rhabdo and what have you. So, but anyway, yeah, that's a good point. That we do see that also. You know, but I put them in the same dumb lump as the other guys. So, so yeah, that's what we want you to consider with these patients, because there is a small subset, and it makes you look. If you do this and it works, it makes you look really cool. I mean, it's really. I mean, this makes you look like a Superman, which is what we want everybody to be. You know, I mean, this is magic. When this works, this is magic, and 6% of the time or so, maybe higher in Bella Vista, this might work. So consider it. Yeah, consider it. Yeah.
So we're gonna add the calcium on the ambulances. We're gonna have sodium bicarb. Looking at doing this rather than retrying to type out a flow sheet and get with Jamin. Jamin has the software for that.
Yeah.
We'll just do an amendment and we'll just put that in front of the protocol.
Yeah, and we'll wait till and then when the committees come back out, we'll throw that in there. Yeah.
So we're gonna go live with this, like,
I don't order calcium.
Yeah.
So you mean if I've got to get a drug medication sheet, I've got to create one of those as well. I haven't gotten there. So I get a drug, I can copy everything off Medscape, and I'm just going to create a drug sheet and with that. Now, while I've got you here, calcium for cardiac arrest. We consider ages and Ts. Could we use calcium in a cardiac arrest as well?
Well, here's the deal. If you look at the research, a lot of the pre-hospital research that really came back, and I think the last time that they had a really good high-quality paper on this was back in like 2003 or 2004 or what have you. And they said it just didn't work. Okay, now intuitively, it makes sense. And I have given calcium in cardiac arrest, and I've seen it work. Of course, I've also seen that it didn't make any difference at all. You know, there was one or two cases that it helped, and most of the time it didn't really make much difference, you know, with it. Now, there were probably multiple other variables that were going on, but it would make sense intuitively that a little calcium would help, because we know that these patients, if we give them more calcium, you know, that 0.5% of free elemental calcium, the muscle does beat stronger, right? So I don't know that it's mainstream. Well, it's obviously not mainstream yet because it's not out in all the guidelines, you know, but those are usually a few beats behind. That I don't know that it's I don't know that we're ready for that. You know, I think there's a subset of population out there that it probably would be helpful for, and it probably would work. But it's the question of finding that subset. And if you give too much calcium, or you give it too fast, or what have you, then it can cause bradycardia, and it can make things worse. And you just got to be ready for that. What I want to be really cognizant with you guys is if we give you too much to do, one, you can't get it done. And sometimes you'll remember part of it. And even though they're super medics, I mean, they just can't do it. You know, if we give you 15 steps of all this stuff to do, you can't do it all. And the more steps you have, the more likely it is that we'll mess something up. So that's the only thing. So when we do add things, then we want to make sure that they are high yield and high return on our investment of your guys' critical time. And then some of this stuff costs money too. I mean, calcium's cheap, but you know, before we put a wonder drug on there that affects, you know, 1% of the population, is it, you know, do we do that for the other 99% of the population? And there's some places that aren't even doing this, you know, because they're like, well, it's 6%. You know, should we be doing this for all, you know, just to catch 6% of the population? Well, if that 6% is your mom or your dad or you or your wife, then hell yeah, you want it done, especially if it doesn't hurt.
Yeah.
And that's what we're seeing is this doesn't hurt, but it might help. And if it does help, it's going to be a game changer, and it might keep us from making a fatal mistake of a clean kill on that. And we sure don't want to do that. So that's why this makes sense.
Yeah.
So I don't know that calcium on all these other patients is there yet. Now, you know, next month, you know, we may talk about something different, research changes, time change. But I don't know that calcium has got enough critical mass, momentum-wise, on all cardiac arrest patients.
Perfect.
Yet.
Yeah.
I guess. Yeah. Does that make sense?
Absolutely.
That's just my general gestalt on it. But yeah, years ago, you know, we gave them calcium and bicarb and Rutilium and all that, and that stuff kind of fell out of favor. And now and then it was, well, vasopressin and amiodarone are right, and how long did that last? 2 or 3 years, you know. Now that's falling out of favor. So that's some of the challenges. All right, what else? What else we got?
Last thing is we talked last month about long-term paralytics.
Yeah.
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 That protocol is done. I don't know.
Yep,
If you,
I saw the email.
chance to see
I
it.
saw the email on it. I hadn't seen the actual sheet, but I saw the back and forth that Ford or somebody's working on. Yeah.
So I thought we'd just kind of just look at it really fast.
Yeah.
While we got you recorded,
Mm-hmm.
and then we can wrap it up and be done.
Yeah, great. So, you guys know when you look at something or when you do something right, you do it that way all the time, and this and that, and you write something out and it makes your notes make perfect sense to you and to really 90% of your coworkers and so forth. And then some new coworker comes in from, you know, out of the area, out of the state with a little different perspective, and they look at it and they go, well, it doesn't read that way to me. And of course, initially you think that they're crazy, but then when you go back and you read it yourself, and you go, oh, okay, well, shit, I understand why they read it that way, or that makes I understand the confusion. You know, it makes sense to us because we were born and bred and trained here in the protocol. And we know why the protocol is the way it is and so forth. But to an outsider, they look at it and they go, oh, I don't really follow that, or that's not the way I read it. So initially you think these people are crazy, but when you read it independently, then you go, well, maybe we need to word this differently, or we need to change it differently, and so forth. And that's what this is all about. We all know, or at least we hope we all know, that when we do a PAI on people, that we want these patients sedated, right? We do not want them locked in. We do not want to paralyze them without them being sedated. One, because it's a nice thing to do. Two, because you know, if you paralyze them and you don't sedate them, it's a very stress-invoking event. And I'm not talking about hurting their feelings. I'm talking about making them tachycardic, you know, causing more adrenal crisis and adrenergic overdrive and all those other kinds of things. And plus, it's harder to assess, believe it or not, it is harder to assess a patient that is paralyzed. You're like, well, I'll just look at the monitor. Well, you know, monitors are not the end all. Monitors can lie to you. Monitors can be wrong. There can be technology issues. There can be a wiring issue. Sometimes the monitor's battery pack dies. I mean, how often have we had that happen? If you haven't had it happen, you haven't been doing it long enough. So we all know how important it is to sedate these patients that we paralyze. We want to sedate them before we paralyze them, and after we get them intubated, we want them to be sedate also, all right? And it is better for them to be sedated than for them to be paralyzed. Being paralyzed is not a benign event. And these patients can go bad if they are paralyzed and not sedated, and we can't reassess them. So we had somebody look at this and they said, okay, well, I sedate them, I intubate them, and now I'm getting down into post-intubation management, and I've given them suction. Now I'm just going to go right to a long-acting paralytic because they all should have a long-acting paralytic. No, we don't. They shouldn't have a long-acting paralytic. We don't want them to have a long-acting paralytic. We want them to be sedate. We want them to control their airway, and we want you to stabilize them. And then we'll make decisions on whether we want these patients to wake up an hour from now, 10 minutes from now, or 3 days from now. If they need a long-acting paralytic, let us help make that decision. Because if you put them in a long-acting paralytic and we get them locked in and we're moving them around, we're moving them from the squad to the ER and the ER upstairs and the elevators and helicopters and this and that, and we pull an airway, which happens a lot. And I can tell you several cases in Arkansas that I've been involved with where bad things happen, and was able to fight for the medic because they were all trying to blame it on the medic that the airway got moved. We don't want you to go just reflexively to all these patients need a long-acting paralytic. Some of them do, but they don't all need a paralytic long-acting. Now, what do they all need? They all need sedation, for sure. So we want you to, once you get them intubated, we want you to really be working about, you know, pain control and sedation and so forth, and don't get hung up on all these patients. As soon as we get their airway secure, they need a long-acting paralytic. It makes more, now, for the patients that do, it makes more sense for some in Bella Vista than it does anywhere else. It doesn't make as much sense now because you have a Bella Vista emergency room. But back before the Bella Vista emergency room, when you had a 20, 30, sometimes 40-minute haul, you know, to Rogers, it made sense for some of these patients to have a longer acting paralytic. But we don't want you to get so hung up on that you miss the sedation. The sedation is more important than the paralytic long term. And that's what we really want everybody to know. Am I saying it right? Am I missing anything? Okay. So don't get so hung up on that you miss the forest for the trees. What are we talking about? Did I cover it all?
That covers everything.
Great. All right, I want to make sure I didn't miss it. We want to make sure I didn't miss anything. And you can drive that in, because what we have seen, and it's not necessarily at this department, although I'm sure it's happened here because it happens everywhere. We have seen some patients use this protocol before the revision, and they give them sucks, and they give them a little sedation, they give them sucks, they get them intubated, and then they go right to a longer or medium acting paralytic, and they forget the sedation because the patient's not talking and they're not moving, and they don't look like they need to be sedated, but they're not paying attention to the monitor and noticing while they're tacking at 110, 120, their pressure's changing and so forth. Now, if you're saying, well, their heart rate's 80 and their pressure's good, they probably don't need much sedation. But you just think if you were tied down and somebody had a tube in the back of your throat, what your heart rate and your blood pressure would be doing if you were conscious and knew that was going on, and particularly if you were tied down and couldn't do anything about it. So, which these patients are if you paralyze them. So that's the main thing there. We've had that happen in Northwest Arkansas a few times at different departments, and I can tell you right now, the state of Arkansas, from an EMS standpoint, is finally catching up. Right? And Little Rock, they are catching up. They're still a long way from doing it, but they are catching up, and they are critiquing and looking at these things and getting questions and so forth. And I'll give you a prime example. The other day I got a call from Dr. Bledsoe, who's over the state EMS part, and we have a smaller agency in Benton County that is wanting to roll out RSI, on there. And he calls me and he goes, "Are you sure? Are they ready? What's their training program? What's their, this or that and that?" And we hadn't had that happen before. All right, so they are really starting to look at particularly RSI and so forth, and making sure that it's adequate. They did it when we first rolled out RSI, and then it kind of went dormant for a few years, and they said, well, no news is good news. But they're starting to look again, and they're starting to do more chart reviews. It's not just me and your EMS chiefs that are reviewing your charts on your RSIs. These are getting reviewed at the state again, and so forth. So, of course, we went back and told him, well, yeah, this is a good department. Most of the medics work on one of our bigger departments. They're just working here part-time. And I made the decision that the medics that are intubated, the medics that we want this department to be able to have that capability. The reason and the way we're doing it is we're only letting the medics that work at a major department, meaning Rogers, Bentonville, or Bella Vista, be able to do RSI. If you're just a medic and you work on one of the transport squads and you don't have a lot of experience, or you're new to this area or whatever, you're not getting the PAI privileges, because you're not doing this enough to stay proficient at it, particularly at a small department. If you're at one of the major departments, we know that you're getting trained, we know that you're getting opportunities to do these protocols and so forth, so we're making it available to them. We don't want them to have their hands tied when they're helping out these smaller departments. So that's where we ended up with that. The state's great with that, and I think that's a great idea. But because if you're on a small department and you intubate once or twice a year, are you proficient? Probably not. Probably not. Okay, that's all I got. Well, hopefully that was of some value to you guys.
Absolutely.
And I'm working night shift tonight, so I'm going to go get a cat nap. So, any questions for me? No? Anything from the skinheads on the monitor there? No.
No, nothing's coming up. They're still there.
I don't know if that was a thumb or a middle finger. I don't know which one that was, but it was a single digit. All right, I'll put that as my exercise. Yeah.